Dr. Hewitt, before we turn to the HCV look back, there's just one further question I have arising out of attempts to trace recipients of potentially HIV-infected blood. Could we look at NHBT 0010151_001, please? And if we go to the second page, this is a letter dated the 12th of December 1994 from you to Dr. Raymond at the Department of Health. It's in the context, as I understand it, of an application to the Department of Health to be recognised as eligible for a payment from the Eileen Trust. And it's not the specific case that I'm going to be asking you about. If we look at the third paragraph, you say this: my one problem with your proposal is that there will usually be other recipients who've been transfused from the same donor. In some cases, this will involve components from the same donation, and in other cases, there may be subsequent donations. I am most happy that the Regional Transfusion Centre is not provided with information which could facilitate the tracing and testing of other recipients who may have been at risk of infection. I've expressed my concern on several occasions in the past. If the Department and CDSC fail to disclose information which could enable the identification of other recipients who are infected and therefore also eligible to submit a claim under the Department of Health scheme, then some individuals will be denied access to the scheme. What was the problem here? Can you recall?
Yes, I can explain. So the case in question related to an individual who had received blood transfusion before 1985. So the blood donors had not been tested for HIV. And you can see that this letter was 1994. And I imagine that we had been asked to investigate the case and had been unable to contact those donors who had donated before 1985 and not since. So there were obviously more than one donor for whose HIV status was unknown. So we could not say whether this was a transfusion-transmitted case or not. The suggestion was made that for those donors whose HIV status we didn't know and with whom we couldn't make contact, that we provided their details in what's called a Soundex code, and that's a way of anonymising a name, and there's a sort of way it's done, using the initial letters of the first name and consonants from the surname, and that makes a Soundex code, which is not unique, but is fairly unique to a name, together with the date of birth. And that is how, that, as I understand it, is how the CDSC, the Communicable Disease Surveillance Centre, held their records of known HIV-infected individuals. So the suggestion was, if we supplied the Soundex code of our unknown donors to CDSC, they could do a check to see whether any of the individuals who we did not know the HIV status of had been reported as HIV positive. And then CDSC could report to the Department of Health and say, yes, there is a positive donor involved in this case, so payment can go ahead. And that's fine. And as I said, I had no objection to that. What I objected to was that there was then no mechanism for the transfusion centre to be told, yes, one of those donors is HIV positive. We know now is HIV positive. And therefore, we could not trace any other recipients from that donor. So there would be other recipients who could be traced if that information was provided to the transfusion centre, but who would not be traced because there was no feedback mechanism to say the transfusion centre must be informed.
And was that resolved?
I don't know.
Well,
I did not have a response.
Well, maybe we can pose that question to the Department of Health in that case. Moving then to the hepatitis C look back. You've observed in your look back witness statement it was very different in some respects from the HIV look back because it was a nationally coordinated exercise with as it were, a direction or letter from the Chief Medical Officer.
Yes.
And that was the formal trigger, is that right?
Yes.
Although the regional transfusion centres had been doing work in advance to be ready.
Yes, precisely.
And you managed the hepatitis C look back for the North London Blood Transfusion Centre and, as you told us yesterday, ultimately also for the South London Regional Transfusion Centre. Now, we know that began in 1995. It might be said that the obvious trigger for a formal national look-back exercise in relation to hepatitis C would have been the introduction of screening in the autumn of 1991. Would you agree with that, first of all, as a matter of principle?
Yes, and I expressed my concern that that was not being done.
And I ask you this not because you were involved in the decision-making, but as someone who was subsequently involved in 94, 95 when, as it were, it came back onto the agenda. Do you have any understanding as to why a look-back was not organised until 1995?
I always understood that that was a decision made by the Department of Health. And my understanding was that part of the justification for that was that there was no treatment available for hepatitis C. So one would be seeking out individuals, establishing whether or not they had been infected with hepatitis C, but then having nothing in the form of treatment to offer them. I found that very strange because, of course, the same could have been said for HIV in 1985. When we started screening donations for HIV, there was no treatment available for HIV infection. So I felt that that didn't appear logical. I think having read Dr. Robinson's statement, where of course she knew far more about the history of it, there seemed to have been a lot of concern, even I think from virologists and hepatologists, that seeking out individuals and telling them they had hepatitis C when there was no treatment available was putting an unnecessary burden on them. And unlike HIV, there was no clear evidence for easy spread to other people, in particular sexual partners. But I still struggle with that because I'm sure that in 1991, when we started screening blood donations for hepatitis C, I mean, we knew there was no treatment available and we told our donors that. But we did say to them that there is one thing you could do which might be of help, because this could cause you problems in the future, and we would advise you to limit your alcohol intake because that could be a factor in making liver disease more likely or worse. So there was something that could have been offered. I know it's quite a burden to people to tell them, you've got this infection, there's no treatment for it, and actually you've got to give up alcohol. But there was something that could have been done to try and minimise the effect. And I don't see that in the discussions. And I see there were a lot of discussions about the burden of seeking people out and telling them they were infected.
And can I just explore with you for your comment, really, what might be said to be three reasons, and I'm not suggesting this is exhaustive, as to why it might be right for people to be traced and told. One is the very one you've already alighted on. So there are lifestyle adjustments that can be made that can have a real beneficial impact upon health if you're hepatitis C positive. Is that right? Yes, and
I'm very sure we were telling our donors that in 1991.
And then a second might be just the very idea that someone ought to have the right to know key things about their body. And we'll see that as a theme that comes back, as it were, to haunt you, I think, when we look at issues relating to VCJD. And the third might be that although, as at 1991, the treatments that became available for hepatitis C might not then have been readily available, but those who, for example, had already got liver damage would benefit, would they not, potentially from knowing that they had hepatitis C, having monitoring of the state of their liver, a potentially earlier identification of something like hepatocellular cancer than might otherwise have been the case?
Yes, and I think we go back to what I said yesterday about HIV when we identified HIV-positive blood donors. We said there is no treatment available at the moment, but unless you're known about at a specialist centre, possibly, and in 1991 it might have been very different with the arrangements for liver disease, but when treatments do become available, then you will be in position to be offered them.
It goes wider than that too, doesn't it? Because from what we understand, there is at least a theoretical something like 5% chance of passing on a hepatitis C infection to somebody else by sex.
Yes, and I think certainly in 1991 it was very uncertain what that risk was. I think it was recognised that the risk was probably much less than for HIV. And I think for HIV, the risk of sexual transmission was known to be much higher, and that was an added reason to seek people out. Whereas for hepatitis C, I think the argument was made, well, there probably isn't as big a risk, so we don't need to worry about that.
But that is equivalent to knowing of a risk and choosing to ignore it.
And I would agree, and there was also, it was certainly not known at that stage, the risk of a mother passing it on to her baby. It just wasn't known. I mean, later it became known that that was very low unless there was co-infection with HIV. But at that time we didn't know. I
mean, you start off with the thesis, it's blood-borne.
Yes.
And so there is a risk of contact between the blood of an infected person and an open wound or sore or for that matter, the child in childbirth in the usual way that there can be a blood contact. So for all those reasons, those are all additional reasons why someone might be told, are they not?
And I agree. I think there was a lot of concern that because those risks were believed to be much less than for HIV, it was a different situation.
Yes.
And so one of the observations you've made in your witness statement, Dr. Hewitt, and perhaps we'll put it on screen, it's WITN 31010006, page 108. And this is about the potential impact of losing those 3.5-4 years. You say this in paragraph 294. Thus, when HCV lookback was eventually mandated in early 1995, a further 3.5 years had elapsed from the point when lookback could have started. As the majority of HCV-infected donors were identified in the first 12 months of screening, we'd lost vital time from first knowing of a donor whose previous donations would require investigation. The time delay was not so great a problem for blood centres, but produced serious difficulties in hospital laboratories, where records were generally kept for a finite number of years, often 10 to 12 years. By the time lookback started, 3 or 4 years of earlier hospital laboratory records would have been disposed of, preventing the tracing of recipients who would receive potentially infectious blood components and who could have been traced if the lookback had started in 1991. Although approximately 50% of blood components are transfused to individuals who die of their underlying condition within 12 months of transfusion, and a further number of blood recipients will die in the following years, the opportunity was lost to identify and trace a small number of surviving recipients transfused in the early 1980s, because the hospital laboratory records had been destroyed in the years 1991 to 1995. So that's a very real and direct consequence of the time lag between the beginning of screening and the mandate to undertake the lookback.
Yes, it is.
If we just look at the top of the page, you say, picking it up in the fourth line, we, and I think by that you mean the blood services, had no mandate to carry out HCV lookback. Without a central directive from the Department of Health, there was little prospect of persuading consultant haematologists in charge of hospital blood transfusion laboratories to divert their already hard-pressed resources into an activity which was not mandated and not supported with additional resources. So is this right? In principle, the regional transfusion centres, blood services, could have undertaken their own look-back, as it were, as an autonomous decision on their part. But the difficulty with that you've identified here would have been securing the engagement of the hospitals in the absence of a central direction from the Department of Health or Chief Medical Officer.
Yes, I mean, it was the size of the work that would be required. It was very different from HIV, which was mandated, because there were small numbers with the HIV lookback. With the hepatitis C lookback, it was much, much bigger. I mean, the two hospitals which North London supplied, which used the most blood components from North London, they each had over 100 blood components to trace in the lookback. And a busy laboratory can't just add that to their normal workload without making some additional resources available.
And do you know what the funding position was in relation to the lookback, how it was funded?
We in the blood service did not have any additional resources. We just had to get on with it and do it. Within the hospitals, there were real problems. Some of the hospitals did need extra resources, and it was difficult for them to get those additional resources. I mean, they managed it, and sometimes it was helpful that we sent sort of a supporting letter saying, look, you know, re-emphasising this is a mandate, it needs to be done. And they would apply to their medical director and say, can we get somebody seconded to help us with this?
Now, if we just then pick up the decision-making in 1994 into 1995 in relation to the decision ultimately to hold the look-back, there was a meeting described as an ad hoc meeting in, I think, Birmingham in August 1994, and I just wanted to pick matters up there. NHBT 0009383. Now, this is headed Preliminary Position Paper, meeting to consider the merits of an HCV look-back policy, 5th of August 1994, West Midlands Blood Transfusion Service Centre. Objective, an ad hoc assembly of experts was convened on behalf of the Standing Advisory Committee on Transfusion Transmitted Infection to discuss the desirability and feasibility of introducing a look-back policy to identify, test, counsel and, if necessary, refer surviving past recipients of blood components from donors later found to be anti-HCV seropositive after September 1991 when screening was introduced in the UK. And then we can see a list of those attending, and we can see that you were present at that meeting, as indeed was Dr. Barbara from North London and Dr. Robinson as National Medical Director of the MBA, and Dr. Williamson, who was asked about this earlier in the week. Can you recall how it came about that this meeting was held?
Yes, I think I can. I was not a member of SACTI at this point. Dr. Williamson was, Dr. Robinson was, Professor Tedder was, and I'm fairly sure that Dr. Aller was the chair of SACTI at that point. And I think that there were sufficient of us within the blood services who were concerned that look-back had not taken place, that we in discussions felt that we in the blood service needed to present a case to the Department of Health to say, look, this really needs to be done. So Dr. Aller convened a meeting with the people, I suppose, who were making most noise, and representatives from SACTI, and also you will see Dr. Mutimer, who was a hepatologist, his local hepatologist, and also invited was Dr. Elias, who was another hepatologist, to get together a position paper to say, this is why this needs to be done. We cannot tolerate a situation where it has not been done.
We can see, and I won't go through the document in its entirety, there's reference at the bottom of the page to a paper by Ayob and others.
Yeah.
I won't take you to that, but just for the reference is PRSC 301046. And then if we go over to page 3, just before I ask you a question about it, this is described as a preliminary position paper, so it's not a set of minutes as such. Do you know who drafted this? It looks like, actually, if I look at the last page, I think it's probably
Dr. Aller.
Yeah.
Yes, I think it was Dr. Aller.
in any event, if we see on page 3, what's the efficacy of treatment in the long term, says there's growing evidence that this is not a trivial virus and that a significant proportion of patients benefit from receiving therapy. Now, leave aside the question of therapy, because that was obviously a developing picture in the course of the 1990s. Describing it as growing evidence that this is not a trivial virus might be thought to be quite a curious way of putting it. It had surely been understood by 1991 that hepatitis C was a serious condition.
I think we've probably heard that during the late 1980s and the early 1990s, views started changing, or that significantly from the it's not a very serious thing to it is a serious thing. I can't account for the wording. I think it was possibly put there to emphasise to those who were still doubters that it was the case, that it was something serious and needed to be taken account of.
If we go to page 4, I just want to pick up on what's said at paragraph 4, the bottom of the page. It was generally acknowledged that we in the blood transfusion service do have an ethical responsibility and duty of care towards recipients of potentially infectious blood components, such that they deserve to be identified, counselled, tested and offered treatment where that is appropriate. It was felt that despite the current uncertainties regarding long-term efficacy of treatment and its impact upon the natural history of hepatitis C, we have a moral obligation to inform and advise surviving potentially infected blood recipients. Again, I don't know whether you can assist with this, but had that been a growing recognition of this moral or ethical responsibility? Was this something that had developed over the first half of the 1990s? Or is this just an articulation of something that the Blood Transfusion Service had long recognised?
I think it's the latter, yes.
And just in relation to the meeting, do you have any independent recollection of the meeting now?
I can remember being in the room. I can remember the corridor leading up to the room. I can't remember. I don't know what you had in mind.
Whether was it ultimately a consensus meeting? Was everyone very much of the same mind as far as you can recall, or were there very much differences of?
No, I think the people in the room had been selected invited because they were the people who really felt very strongly this should be happening, and we were trying to present the case to the Department of Health in as strong terms as possible.
And then if we go to the next page, we can see in paragraph 5 there's a brief review of the policies of other countries. And then the heading is the options for the UK BTS are, and then 2 options, confine itself to the role of an information clearinghouse, providing hospitals with the identity of implicated blood components, leaving it to them and GPs to follow up potential recipients. So that would be the option, would it, of the National Blood Authority itself initiating its own look back, but then ultimately having no power to compel hospitals to do anything in particular in response?
No, sorry, I think it was that the blood service would merely provide the information to the hospitals and leave it to them to get on and do whatever was necessary together with clinicians and GPs looking after the patients, in contrast to the second paragraph.
Okay. And we can see that first option is described as it was felt that this policy would not be effective in practice. And then 2, trace implicated recipients through hospitals and GPs, interview and counsel surviving recipients, obtain and assess a sample of blood, refer infected patients for specialist counselling, investigation and possible treatment by hepatology centres. And that was the option that was favoured by the meeting.
Yes. And it does note it was not clear how the added costs would be defrayed.
And then if we go over the page, there was an estimate in relation to what the overall caseload might be. And then the decision of the meeting, we can see in the last 4 lines, the meeting felt that there's a serious case for considering the implications of an HCB look-back policy in its operational detail and wished to refer the topic to the NHSBT, so the Advisory Committee for the Microbiological Safety of Blood and Tissue, with a recommendation that such a policy is implemented.
Yes.
And as I understand it, that's what was done. I know you
Yes.
weren't on the MSBT, but a recommendation was made to the MSBT.
Yes.
Was any consideration given, as far as you can recall, to the possibility at this time of conducting or inviting the Department of Health to conduct some form of broader public health campaign? Because what was being recommended here was limited in scope, because like the HTLV3 lookback, it would bite only on donors who had come back after September 1991.
It was a targeted look back. I don't know whether there were any discussions either within the blood service or at MSBT about a wider public campaign.
I won't go to the MSBT decision, but for the benefit of the transcript, it's PRSC 000365, 15th of December 1994. Can I then pick matters up in January 1995 when you were involved in discussions and planning about, in practice, how the look back might be undertaken? So if we go to NHBT 302755, please. This is a letter of the 16th of January 1995 from you to Dr. Robinson. You're commenting, I think, upon a proposal. You and Dr. Barbara were commenting on a proposal or protocol that had been put together by others. And then if we just pick it up towards the bottom of the page, action by haematologists at the hospital. In our experience, haematologists are usually able to return information very quickly if there are computer records available in the blood transfusion laboratory. The further back the donation was transfused, the more likely there is to be a delay, since computer records were not generally introduced until the late 1980s. The major reason for delay is likely to be difficulty in locating the medical records. So that's the patient's medical records, is that right?
That's correct, yes.
The haematologists have no control over storage of medical records, and this may well be a major stumbling block. This may require input from sources other than the transfusion service. And did your prediction prove to be correct, that this was a problem?
Yes, and if I can just explain, there was a step that the patient medical records should be inspected. First of all, to establish from the blood transfusion laboratory records, it's only possible to identify the name and date of birth of the patient. There would then need to be a step to say, did this patient actually survive the episode? Are they still under hospital care? If not, who is the GP? There was something else. Anyway, and that needed to be completed from the medical records. So the blood transfusion laboratory could do their piece, but then the haematologist was expected to complete the rest from the patient medical records. And that was a major issue.
And then if we go over the page, there's a heading, action by clinician in charge of the patient at the time of transfusion. Your suggestion was that it would be unnecessarily complex to involve that clinician. Is it right to understand that's because they may have not had any responsibility for or dealings with the patient for many years by that point in time?
Absolutely, and if a patient was transfused during the course of, let's say, a hip replacement operation 9 years ago, now writing to the consultant orthopaedic surgeon who was in charge at that time and saying, we now know this, do you want to contact that patient and counsel that patient about possible hepatitis C infection? Well, that was just completely ridiculous as far as we were concerned. And it as you say, we were commenting on a protocol which was basically drawn up by others.
And then we've got a heading, action by GP. The major issue here is who should perform the counselling. Many GPs will not feel themselves equipped to carry out this task as they have no in-depth knowledge of the issues relating to hepatitis C testing. The most obvious solution would be for the transfusion service to train appropriate staff, possibly nurses, to carry out this work, but there will be resource implications. There is, however, no obvious alternative. Certainly in our area, we would see the majority of GPs unable/unwilling to take on this task themselves. What happened in relation to that issue? First of all, in terms of what was agreed as the national protocol, and then in practice in your area?
So what was agreed was that the individual who currently had the care of the patient, and that might have been a hospital clinician, in which case it was less of an issue, but usually a GP, would be contacted and asked, is it appropriate for this person to be now notified? And if so, would you like to do this? And that was what was in the agreed protocol. And as we predicted, many GPs did not feel they would be able to carry out that process, and then referred it back to the transfusion centre, who did not have any additional staff to carry out that work.
And so what happened in those cases?
So it was done without the additional resources, and as I said in my statement, other things that we might have been doing at the time were postponed until we had sufficient, until this exercise had been carried out and we could go back to our day-to-day work that wasn't being done.
In relation to North London, South London, your team ended up directly dealing with recipients.
Yes, we dealt with many recipients.
Because the GPs were reluctant to do so?
Yes. Not all. Some GPs were very happy to carry out this work, and as I said, many patients were under hospital care, and it was done in that arena.
And did you gain a sense of how widespread a problem that was? Were there other transfusion centres having to do likewise?
I'm quite sure there were, yes.
And then, can we go to the next page, please? Just the heading at the top of the page, stored donor samples prior to September 1991, where donor has not given blood since. So this is the cohort, the potentially huge cohort, yes, that was not covered by the HCV lookback because it was a targeted lookback in the way you've described. You say here the work involved in defining which samples relate to donors who've not been tested for anti-HCV is enormous. Furthermore, RTCs have different extents of archived samples, and the approach must be consistent across the country. There would be enormous operational problems on top of the ethical and legal considerations. Very often it will be impossible to adequately confirm an ELISA reaction on a stored serum sample, which is likely to be of small quantity. For these reasons, we would not advise any plans at present to test stored donor samples for donors who have not given blood since September 1991. Can I just try and unpick that with you? The second paragraph gives a sense of, well, let's start with what we know we can do and what we should have been doing since September 1991, which is test and which is trace, look back in relation to those donors who've returned to us since September 1991 and where we know the position in relation to their blood because it's been tested. And as it were, you're putting off the possibility, but not ruling it out, of a bigger exercise. Is that right?
Yes.
Now that bigger exercise wasn't then undertaken, but what were the ethical considerations, first of all, that might have made that difficult, that you allude to here?
I'm not sure.
The practical or operational difficulties, again, what were those? One can see it's a less straightforward exercise, yes, than the one that was undertaken, but and it might not have been possible to do it perfectly or comprehensively, but some steps could have been taken, could they not?
I've been trying to go over in my head what it would have been involved. First of all, I think it's important to explain that a sample is retained from every blood donation for a period of time, and that sample is microlitres of plasma which are removed from the sample tube at the time of testing and then transferred into what's called a microtiter plate, which is a plastic plate with a number of wells, 96 wells, and each donation sample would go into one well, and it would be microlitres of the sample. And then when the 96 wells were full, it was frozen in long-term storage. And those were kept, as we've said, for a finite period of time, usually because of space restrictions. You can imagine at North London we were taking 200,000 blood donations a year. So the numbers of trays that one needed to keep deep frozen mounted up. There would have to have been an exercise to identify which donors, for example, attended in 1989 and hadn't attended after 1991, and that would actually have been an enormous exercise, because you would have. I can't get my head around how we would have done it, to identify all the donors who'd attended in that year, and then interrogate the records to see if they'd attended again after 1991, and then drawn up a list for each year of those donors, and then identified whether there were donation samples stored, and if there were, identify which of the many thousands of plates that sample was in, removing the plate from storage, thawing it, identifying which of the 96 wells on the plate belonged to that donation, taking the tiny sample of plasma out of the plate into a tube, and then putting it through an HCV test. And it was an enormous exercise. It couldn't have been done within the resources we had.
So I can understand from your description that it's not a straightforward or easy exercise. Might not have been a perfect one. It might have been possible to do something, is this right, but with significant additional resources being provided?
It would have been very significant resources.
And I mean, would the logical way to have done it would have been to go back from September 1991 backwards, as it were, year by year?
Yes, and as we've said, by 1994, many transfusion centres would not have had any samples prior to 1991 because they were discarded on a rolling basis, often after 2 to 3 years.
I'll come on to in a little while what other measures might have been put in place, not necessarily by the transfusion centres, but by the Department of Health, the public health campaigns and so on. Would another possibility have been, in principle at least, the blood transfusion centres contacting donors whose records you would have, who had not returned since September 1991, to invite them to come and for the purpose of a form of testing or screening, so that you could then know which previously implicated donations you had to follow through? Would that have been an option in principle?
In principle, yes. In practice, again, it is an enormous exercise because records were not kept in the way that we could easily identify which donors had donated and not donated since, if that makes sense. The records that the Transfusion Centre kept enabled us to do lots of different things, but to say, let's identify all the donors who came in 1989 who didn't come after 1991 was not something you could do at the press of a button.
So it would have involved some form of interrogation of records rather than a simple computer.
Yes, and many of the records were not on computer because we're talking about the 1980s and they were paper records.
So again, would it be right to understand that it might have been possible to do something, but it would have required additional resourcing, significant additional?
I would say very significant additional resources.
Can we then just look at a later letter from you to Dr. Robinson in March of 1995, NHBT 0096456, please? We can see that you say to Dr. Robinson here, I visited our two largest users of blood/blood components and discussed with consultant haematologists and the chief MLSOs the procedure for the HCV lookback. Lookback will create significant demand on hard-pressed resources at hospitals. And then it would appear that those hospitals had asked you to pass on two major concerns. One was the problem in relation to records and the need for staff to be involved manually in working through records. Is that how we understand the paragraph beginning firstly?
Yes.
And then secondly, is the problem you've already identified in relation to obtaining patient case notes. And then you say you sympathise fully with the situation in which the hospitals find themselves. The transfusion staff will do their best, but this exercise is dependent upon factors outside their and our control. Again, this is obviously you reporting back your local experience.
Yes.
To Dr. Robinson. Do you know whether others who were performing the same exercise in other areas were getting the same feedback and experiencing the same difficulties?
I don't know for certain, but there would have been. I mean, the two hospitals named here were our biggest users and were probably some of the biggest users in England. But there would have been other hospitals which would have been significantly affected in the same way.
The Chief Medical Officer's announcement of the look back, I'll just go to it for the sake of completeness. NHBT 302737. We can see it's a letter 3rd of April 1995 from the Chief Medical Officer, Dr. Coleman, sending this letter to doctors to inform them of the guidance and procedures for the look-back exercise announced by Tom Sackville, Parliamentary Secretary of State, on the 11th of January 1995. And then if we go to the 3rd page, I'm not going to go through it, but this is the guidance that was issued nationally as to how it should be undertaken. Is that right?
Yes.
And if we go to page 5, just want to pick up what's said here and then ask you about it by reference to a letter from you. So under the heading General Principles of Look Back, it says the presumption will be that each identified recipient would be counselled and tested. However, in exceptional circumstances such as severe psychiatric illness or terminal physical illness, the consultant or GP may feel it inappropriate to add to the patient's distress. So that was the Chief Medical Officer identifying as an exceptional situation, a circumstance in which the recipient might not be told
Yes.
that they had been transfused with an implicated donation. Is that right?
Yes.
And then can I then ask you to look at NHBT 0015661. This is a letter from you, September of 1995, and it's addressed to solicitors who were advising you or advising the National Blood Authority. And you've said in the second paragraph this: during the course of the HCV lookback, we, consultants at the transfusion centres, on occasions receive a view from a general practitioner that in the GP's opinion a patient is unsuitable for notification and counselling on the possibility of HCV transmission from blood transfusion. In some cases, this is because of dementia, general medical condition, brackets terminal malignancy, or that the patient would be emotionally unable to cope with the information. Next paragraph. In these cases, I generally discuss the matter with the GP and note that we've agreed that the patient should not be notified and counselled. The question has now been asked from a medico-legal point of view, should the patient's next of kin be informed? And it was that specific issue upon which you were seeking legal advice, I think, about
That's
informing
correct,
the next
yes.
of kin. What I want to ask you about is what's set out in the second paragraph, so not the next of kin issue. Now, I can understand that there might be cases in which the health of the patient is such that they essentially lack capacity to take decisions about their medical treatment, and it would not be possible or practicable for them to be told or tested. and an example is given there of dementia or of terminal malignancy, so someone perhaps who is already in the last few weeks of their life. It's really the third category given there that I wanted to just probe with you a little further, Dr. Hewitt, or because the patient would be emotionally unable to cope with the information. Now that potentially sounds like it's involving a paternalistic judgment on the part of the GP. I won't tell Mr. or Mrs. X because they'd be upset, which doesn't seem right in terms of the ethical or moral imperative to inform the patient.
I agree, and all I can add is that we're talking about 25 years ago, and I do believe, I know the issue of paternalism has been mentioned before, that things have changed significantly in the last 25 years, and what was considered acceptable practice 25 years ago would not be considered acceptable practice in 2021.
So this suggests that there may have been some cases, and almost certainly one would have thought not limited to the London area,
Yes.
In which individuals may not have been told, even though their GP knew, because the GP had made a judgment that they should not be told.
Indeed, and I know I have seen in some of the documents a case where one of my colleagues argued very strongly against the GP's opinion, and that did come back to bite later.
Okay. And I'm not sure that this is a question you'll be able to answer, Dr. Hewitt, but do you have any sense of how many type cases there might have been? And you describe it here as being on occasions. And
the emotionally unable
yes.
to... I think very few. I think in my experience, the vast majority were individuals who were very elderly at the end of their life or demented. I didn't personally have the experience of that, and I did discuss most of these cases with GPs, so I can't recall it.
May I just ask, in the case where you say it did later come back to bite, which party did it bite?
Well, the blood service later was contacted to inquire about whether a case could be investigated in somebody who had received a transfusion and was now known to be hepatitis C positive. And when the records were examined, it was a case where my colleague had tried to convince the GP that the individual should be aware that the patient had been exposed through a blood transfusion. That hadn't happened. So the patient wasn't aware many years later, and it all went round in a big circle. But I don't think it came back to bite the GP, but it was a case where we had tried to say, look, this should happen, and it didn't. So
it's still unclear to me, really, whether you were the bitten or
no,
the GP was.
In the case of that, my colleague, had a great deal of additional work to sort of untangle what had happened and why, because we knew about this case, if you see what I mean.
Yes.
And then if we can look at NHBT 0096432_002. This is an update from you as at October of 1995 about resourcing issues. I thought I should alert you to the fact that we're beginning to experience problems in accommodating the number of recipients who require counselling through the HCV lookback exercise. As you'll be aware, the department anticipated that the bulk of counselling would be carried out by GPs. Unfortunately, especially at NLBTC, this is not the case. And the next sentence describes the situation you've already told us about. And next paragraph, we all recognise that we have a duty of care to the recipients and they should have benefit of expert counselling based on sound scientific knowledge. I'm nevertheless concerned about the numbers of recipients requiring counselling at NLBTC and the additional workload this is creating. I've instituted a number of measures which I hope will spread the load amongst the available counselling staff. The situation will be kept under review, and then you say you may need to recruit additional help and that will have a cost implication. In practice, how did it pan out? Did you have to recruit additional staff?
We didn't recruit additional staff. I had a very good small team of people who worked very hard to make sure that we could carry out the work, and we did. I'm pretty sure we didn't recruit any additional staff.
And over what period of time, roughly, was this look-back exercise undertaken?
I can't actually say. I would say the bulk was done within a few months, but as I think you will have seen from some documents, information did not come back from the hospitals all at once, and some hospitals took more time than others to return information to us. So it was over a period of time. I would have said within months.
Just one discrete issue. If you had a donor who'd donated in 1991 and you were now, you might have counselled them in 1991 as part of the implementation of the screening exercise. To what extent would they, either then or when you were undertaking this look-back exercise, would there have been an attempt to join the dots between different regional transfusion centres? Would you have tried to find out about, at the look-back stage, other transfusion centres at which a donor might have donated to pass that information on, or should that already have been...
That would have already been done at the initial stage in 1991.
Can we then pick matters up at the beginning of 1996, PRSC 0001490? This is a letter dated the 12th of January 1996 from Dr. Raymond, I think, at the Department of Health, to all members of MSBT and Hepatitis C Look Back Working Party. Is this a letter that you'd have received at the time?
No, because I wasn't a member of MSBT and I was not a member of the Hepatitis C Look Back Working Party.
Well, if I can just invite you in any event to look at what's set out here. It says at the recent MSBT meeting, it was noted that the look back had been slower in achieving its objectives than had been predicted. A number of options on the way forward were considered, and I would be grateful if you could say whether you agree with our understanding of what these were before we submit these options to the Minister. 1, continue look back using the present strategy and with central exhortation to speed up the process. 2, abandon the look back entirely and offer hepatitis C tests to anyone who's been transfused. 3, continue with the look back but offer assistance to overcome the bottlenecks due to problems in tracing hospital records and a shortage of suitably trained counsellors. 4, the committee considered these options but unanimously concluded it was important to continue with the present strategy. This has been carefully designed to identify and offer counselling and treatment to recipients of blood transfusion units implicated in the look back in a structured way that would maximise benefits to them. And then 5 says the committee agreed that a delay in the identification process that might be extended for the rest of 1996 would not disadvantage patients as the evidence was of a 20 to 30 year time frame for liver damage to occur. And I just ask for your thoughts on the options that were there identified, recognising that you weren't at the time involved in this decision-making process or a member of MSBT. Option 2, offer hepatitis C tests to anyone who'd been transfused. Now that could have been done to some extent, could it not? Not by the regional transfusion centres because you're not giving transfusions, but as a national NHS Department of Health-led initiative. Would that be right?
That is correct. And I don't know whether considerations were made into how that would happen. In theory, blood transfusion laboratories could produce lists of everybody who'd been transfused at their hospital in a certain year. then there would have been a need to check records to see how many of these people were still alive and where they were, and then they would be contacted. Or the alternative is to do what was done in other countries and say, make public health announcements and say anybody who's had a blood transfusion should come forward to have a hepatitis C test. And I've pointed out that not everybody knows they've had a blood transfusion, and conversely, many people think they've had a blood transfusion who haven't. So that would also be imperfect. It would obviously identify some individuals who wouldn't have been identified in the look back, but not all either. And I don't know whether those were considered.
And so, in any event, from your perspective, at the regional transfusion centres implementing this, what effectively happened, as I understand it, was that the look back simply continued.
Yes, and
with chasing letters having to be sent to hospitals, and we've got some examples from you.
Yes, I wrote quite a lot of those. I think the first option was one that the blood service was wanting to drive forward, a sort of a departmental message to hospital managers to say, look, you know, this needs to be dealt with. Rather than individual transfusion centres sending reminder after reminder letters to hospital consultant haematologists saying, we're still waiting for the information. And
from your perspective, was there a central exhortation or a sufficient central exhortation?
No, I think that's what we were pressing for, but the department held off that.
And so you were left essentially to deal with it with your local hospitals?
Yes.
I'm not going to go to the letters themselves, but I'll just, for the transcript, give a couple of references to letters from you in the course of 1996, encouraging or chasing the hospitals you were dealing with, NHBT 0076980 and NHBT 0022757, both of which you've exhibited to your look-back statement.
But could I add
yes.
something there? Just a very small point. I wrote a lot of reminder letters, and I tried to make those helpful and encouraging, and didn't always have responses to those. But I did have one formal complaint from a hospital against me for writing the letters.
Can we then just look at some observations you make about the look back in your witness statement? So WITN 3101006, picking it up at page 140. So bottom part of paragraph 374 is the point you've already alluded to. You say in the last few lines, as matters progressed, or in some cases didn't, Dr. Robinson suggested a further formal communication by the Department of Health to encourage particularly slow hospitals, but this suggestion was not thought appropriate. It was therefore left to the blood service to offer underperforming hospital laboratories encouragement, advice and reminders. And then you deal with, in the next paragraph, with the difficulties in terms of the delay and records not having been kept. If we go to the next page, paragraph 376, last four lines, you say, although it was not possible for them, that's the hospitals, to opt out, the speed and efficiency with which different hospital laboratories and individual clinicians engaged in the process was very variable. Next paragraph, not all hospitals or individual clinicians were enthusiastic. Some did not understand the process, many did not have any available resource for what could be a significant exercise, and there were often gaps in the information that they were able to provide. And then paragraph 378 refers to the fact that, at least in terms of your area, the clinicians within the blood transfusion centre had to take on the role of counselling, informing recipients.
Not all. I mean,
in some cases.
In one of our hospitals, they took on the whole task themselves.
And then if we go over the page, we can see paragraph 379 refers to a particular problem in relation to bottlenecks. So there were a whole load of responses that were essentially still awaited. Is that right?
Yes.
And if we go to the bottom of the page, paragraph 380, it refers to a discussion in May 1996 in which it was minuted that the approach via the MSBT for a circular letter to be sent to all chief executives of hospitals concerning the slow response of hospitals to requests for information to the HCV lookback exercise had not been approved. The MSBT wanted the specific poor performer hospitals to be identified. Peter Flanagan asked how we should define a non-performing, poor-performing hospital. Dr Robinson responded it was necessary to use personal knowledge of each hospital and ask if they'd really tried their best or whether their performance was due to a lack of resources. The recorded action was for the 3 zonal directors to send a list of hospitals to Dr Robinson, and she would then write to each hospital. So again, it was left to the National Blood Authority and its directors,
yes,
essentially to try and encourage as much as possible hospitals to respond.
Yes.
And do you think it would have made a practical difference if there had been some form of mandate or encouragement or warning, however it might have been expressed, from the Department of Health or the Chief Medical Officer?
I personally think that in some cases, the issues that the consultant haematologist was experiencing was not supported by the medical director or the board, and so extra resources were just not made available. And I think if something had gone from the department to chief executives, it might have moved the issue up the agenda.
Understood. Can I then just ask you about a document at NHBT 0004632? In May 1998, it's a letter from Dr Flanagan in his capacity as chair of SACTI to national medical directors in relation to HCV infections probably inquired by Transfusion. And it says, my purpose in writing is to outline recommendations agreed at the meeting of SACTI in March of this year in relation to the requirement to follow up reports of possible transfusion acquisition of HCV identified within the PHLS or Diagnostic Laboratory Network, and it records the issue having been brought to the attention of SACTI some time ago. Just picking up a few lines further down, in many instances the patients had not been identified through routine investigation of cases by local blood centres, nor through the National HCV Lookback programme. Dr Pat Hewitt, in conjunction with staff at CPHL, was asked to identify practical mechanisms whereby such cases might be investigated, and then various details are set out. Can you, first of all, just help us understand what the issue was that was being addressed here, and then how it was tackled?
So the first thing I need to say is I really can't remember very much about this, but I can see from the first paragraph that this related to hepatitis C was a notifiable infection. So when a case of hepatitis C was identified, it was reported to the Public Health Laboratory Service. And very often the information would include the possible source of infection, because local public health teams would investigate a case. And if the report that arrived at the Central Public Health Laboratory Service indicated that transfusion was believed to be the source of the infection, there should be some mechanism to establish whether the blood service had been informed of that case or was aware of that case. And if they were not, then it was possibly a case which had not been identified through lookback, and therefore it would be of relevance for that to be known to the blood service.
And then if we look at the third paragraph, it refers to a paper that had been tabled at a SACTI meeting, and then says the paper assumes that all suspected transmission related to transfusion of anti-HCV tested blood i.e. transfused after September 1991, are already being fully investigated. The proposed scheme will apply to transfusions taking place between 1988 and initiation of routine testing in September 1991. 1988 was selected on the basis of medico-legal consideration arising through the current HCV litigation process. And then it continues by saying that the coordination of the project would be through CDSC, and then it describes at the bottom the project aims to provide a pragmatic solution to a difficult problem. So the 3-year period that was selected, 1988 to 1991, appears from Dr. Flanagan's letter to have been selected because of an awareness that might be thought to be a particularly problematic period for the National Blood Transfusion Service because of the product liability issues that were under consideration in litigation.
Yes, because there'll probably be people who are not aware of the significance of that. The Consumer Product Liability, Consumer Protection Act, has a 10-year limitation so that a claim can be brought under product liability. Sorry, I shouldn't be. 10 years, up to 10 years after the date that the product was put into circulation. And the hepatitis C litigation was under the Consumer Protection Act, and it was evident that the precedent having been set, a person who had been infected within that 10-year period could bring a claim under the product liability legislation. And I think, and as I say, I have very little memory of this. This was an attempt to make sure that individuals who fell in that category were identified and knew that there was a possibility that they could bring a claim.
And it tells us it's going to be coordinated through CDSC. Do you recall now what role the regional transfusion centres had, or what, if any, role you had?
Well, from this letter, it appears that the Communicable Disease Surveillance Centre would be notifying the Transfusion Centre when they were aware of a case that fell within this thing. But I have no recollections of that happening.
Okay. And then could you look at PRSE 0004329, please? This is an article, I think it's dated, received for publication 1990, I'm sorry, I'm just looking at the very bottom of the page, accepted April 1991. And it's an article in a, I think, journal called Health Policy, headed Let's Look at Human Immunodeficiency Virus Lookback Before Leaping into Hepatitis C Virus Lookback. I don't want to go through the detail of it with you. It's an American article, as I understand it.
Yes, Mike Bush was San Francisco.
So what it details is a number of aspects of the US experience. But there were just some general observations I wanted to invite your comment on. If we go to the last page, sorry, not the last page, page 7. And we look on the right-hand column, second paragraph. So beginning in light of the date, thank you. In light of the data showing the very limited efficacy of previous look-back efforts, we are warranted, indeed compelled, to transcend these approaches. I am convinced that the appropriate response to this situation is an aggressive education campaign for both physicians and the lay public about the risks and benefits both in the past and the present of transfusions. We need to disseminate information about the risks of all transfusion-transmitted diseases, both to previous and future transfusion recipients, in a well-orchestrated and long-term education campaign. This process should stress the importance of regular donations by low-risk individuals, as well as our commitment to and ongoing research on safer transfusion medicine policies and procedures. We should continue to accelerate our efforts to educate practicing physicians about the indications for and risks of homologous and autologous transfusions. We should encourage all physicians to seek detailed transfusion histories from their patients and, on the basis of clinical findings and dates of transfusions, to test their patients for relevant viruses or diseases. The long-term gain from such a commitment of limited resources to transfusion medicine education will far outweigh the minimal short-term yield of any specific HCV look-back effort. Is there anything there you disagree with?
There's nothing there I disagree with, no.
And to your knowledge, was the kind of well-orchestrated and long-term education campaign with a number of different objectives here described implemented in the United Kingdom?
I think we've heard about Better Blood Transfusion Initiative, the SHOT Initiative, the regional transfusion committees, hospital transfusion committees. Those were all part of that exercise.
So those capture part of what he's talking about.
Yes.
Better use of blood.
Yes.
Essentially. But another part of what's being described here is ensuring that physicians proactively talk to their patients about whether they've had transfusions or might have had transfusions, and if so, arrange for them to be tested, which might identify a number of individuals who've been infected with, for example, hepatitis C, who wouldn't be caught through the targeted lookback.
Yes.
And that wasn't done, was it?
That wasn't, and I think I've probably mentioned it, and probably others have as well. GPs, for example, would not necessarily know that a patient had been transfused because it was not information which was historically included in hospital discharge letters. It might be, but it might not be. So unless one talks to the patients and asks them, that information may not be available.
And another problem that the inquiry has had reported, as well as a GP's lack of information about or lack of access to information about transfusion, is a lack of information, lack of knowledge about infections such as hepatitis C. Do you, from your perspective in transfusion microbiology, have any observations in relation to that?
Well, I think we've seen that when the hepatitis C lookback programme started in 1995, many GPs felt they did not have sufficient knowledge about hepatitis C to adequately discuss the situation with individual patients. I think now awareness is very much greater, but GPs are asked to absorb an awful lot of information about an awful lot of things. I used to say I'm very lucky because I have to know a lot about a very limited subject. GPs have to know an awful lot about numerous different subjects.
And recognising that, is that one of the reasons perhaps why the suggestion, sorry, could we just have that back? Of a long-term education campaign that's directed not just to doctors but also to the public could be important, because that might help individuals understand that there might be causes for symptoms that they're experiencing that they hadn't otherwise appreciated. And
yes.
They might be more likely proactively then to go to a doctor to say, could I be tested? So it's about educating the public as well as about educating doctors.
It is, without then having a huge army of the worried well inundating GP surgeries with anxiety, which would be unwarranted. It's a very difficult balance to make.
Now, not suggesting that the kind of public health campaign that's described here would be the responsibility of the blood service. It would have potentially a part to play. But, it would presumably have had to have been something much wider across the whole NHS and therefore led by Department of Health or Departments of Health in the four nations of the United Kingdom, chief medical officers perhaps. Do you? We've looked at decision making in the first half of the 1990s and leading up to the implementation of the Look Back programme in 1995. Do you recall after that, once it was concluded and it would have been apparent, indeed would always have been known, that there'll be lots of people who hadn't been identified? Do you recall whether there were discussions within the blood transfusion service about this kind of exercise being identified in this article, or any recommendations made to the department?
I don't recall that.
So that brings me to the end of my look-back questions in relation to hepatitis C for Dr. Hewitt, so it might be a good point at which to take our morning break.
Yes, well, let's do that then, and come back at 11:45. 11:45.